Hi everybody, thank you for joining us today and welcome to Funding Primary Prevention, Overcoming Challenges with Innovative Financing Mechanisms. This webinar is being hosted by Mental Health America and SAMHSA, the Substance Abuse and Mental Health Services Administration. I'm Teresa Nguyen, the Strategic Policy Analyst at Mental Health America, and I will be moderating this session. Identifying sustainable financing for primary prevention is a challenge throughout human service sectors. Although many sectors, mental health and substance abuse, general health, education, public health, child welfare, and juvenile justice are concerned with individual and community well-being, the financing policy and programmatic divisions makes collaboration between sectors difficult. So in an attempt to better understand the financing landscape and promote understanding between human service fields, this webinar will review the challenges of our current system, explore major existing funding mechanisms, and share emerging and innovative public and private financing strategies that can be utilized for primary prevention interventions. New opportunities from the Affordable Care Act and interest from private investors will also be highlighted. In addition to a review of financing mechanisms, case examples of innovative, sustainable financing strategies will be presented. In Washington State, the use of Medicaid funds to reimburse PPP programming will be reviewed. In Oregon, one coordinated care organization is prioritizing prevention by implementing a universal intervention, the Good Behavior Game, in county public schools with Medicaid funding. So before we begin, I just want to mention a few logistical things. All attendees are muted. If you have questions for the presenters, please write them down in the chat box and we will address them during our 2 question and answer sessions. Recording of today's presentation will be available on Mental Health America's website within the next 2 weeks. So to proceed, I'd like to introduce Richard Moore. Richard? Are you on the line? Press star 7 to unmute. No. So Richard, hopefully he'll jump on the line, but I'm going to go ahead and introduce him. Richard Moore is the Acting Deputy Director for the Center for Substance Abuse Prevention at the Substance Abuse and Mental Health Services Administration. A 25-year veteran of public health service, he is responsible for providing leadership and oversight of CSAP's operational activities to create communities where individuals, families, schools, faith-based organizations, and workplaces take action to promote emotional health and reduce the likelihood of mental illness, substance abuse, including tobacco and suicide. Richard? Maybe Richard might join us. Alongside Richard, I'm going to introduce our speakers, Sarah Steverman and David Shern. Sarah Steverman is adjunct faculty at University of Denver's Graduate School of Social Work and an independent consultant. From 2008 to January 2013, Sarah was the Director of State Policy at Mental Health America, where she worked on issues related to health reform, prevention, and financing. Dr. David Shern is Senior Science Advisor to Mental Health America and a Senior Associate in the Department of Mental Health at Johns Hopkins Bloomberg School of Public Health. Formerly, he served for 7 years as MHA's President and CEO. Prior to that, he was Dean and Professor at the University of South Florida's Mental Health Institute. David and Sarah will be providing an overview of the challenges and opportunities of prevention financing and introduce emerging possibilities of utilizing health insurance for primary prevention interventions. Sarah and David?
Thanks, Teresa. We'll just go ahead. Hopefully Richard will join us in a bit, or we'll figure out if there's been a technical problem.
We'll put up a little thing to just let Richard know to interrupt us.
Yeah, because we really
okay,
do.
Great.
Yeah, Sarah and I really do appreciate the support that we've gotten from SAMHSA to do this work on financing. And so we're anxious to hear Richard's introductory remarks so we can clear up whatever technical problems are ongoing. But we also want to highlight the fact that the opinions expressed here are our own and do not reflect that of SAMHSA or the Department of Health and Human Services. So as Teresa was saying, what we want to do today is really talk about the challenges of declining human capital in our country. We feel that we're actually in a perilous position in terms of many indicators of our productivity and well-being are heading south, are getting worse, and that we feel that there's a pretty compelling theory actually about some important things that are underlying our declining human capital, and that behavioral health and financing behavioral health prevention and treatment interventions is a critical component in this. We also feel if you look at what's been happening with regard to things in the Affordable Care Act and other general discussions about health care in our country, that there's an increasing emphasis on both the more successful prevention and treatment of chronic illnesses and prevention more generally. And as you'll see when we present our sort of general theory, we think that we can make a pretty strong argument that behavioral health is a linchpin for helping to deal with these problems with both our human capital and with the expensive nature of the treatment of chronic illnesses. We have a couple examples that are sort of spin off the work that is highlighted in the Affordable Care Act in terms of innovating financing schemes. Lane County, Oregon, is using Medicaid financing to finance a primary prevention intervention, which from our perspective and to our knowledge is the first time that kind of financing has been used. And then our colleagues in Washington State have done a very interesting job in terms of understanding components of the PPP intervention and getting Medicaid financing for them. So we think that both of those themes clearly relate back to sort of the changing healthcare financing scheme. And then finally we'll end up with a discussion of private investment and some of the most innovative and cutting-edge financing mechanisms that focus on social impact bonds and other kinds of pay-for-performance mechanisms that might start to more powerfully bring private capital into the equation. And Max Weinberg will be talking with us about that.
Hi.
Great, thanks, David. I do have Richard on the line.
Hi.
Oh, okay.
Richard.
Hey, Richard.
Hi there. I have to apologize for being a bit tardy. We had just a bit of a technical problem here on this end. But I wanted to take a moment to, on behalf of SAMHSA, to welcome all of the individuals that are participating on this webinar this afternoon. This is going to be a very important discussion on mental, emotional, behavioral prevention financing. And I just wanted to take a moment to thank everyone for participating. Thank all of the speakers for participating in the process. The emerging approaches in mental, emotional, and behavioral prevention financing open up an exciting possibility for the field. Yet this will be an ongoing process for engagement, trial, and adjustment. The webinar will reflect upon steps in the evolution of prevention in behavioral health. This progress has come about through the use of data-driven systems and collaborative resources and processes, such as the SAMHSA Strategic Prevention Framework. This evolution has created new norms for the way the prevention field does business and has increased its credibility. There's a growing recognition of the concepts between substance abuse and mental illness and their role as contributing factors of wellness that has been a key to MEB prevention's growth and development. This public health perspective has driven the evolution of prevention as a risk-focused, evidence-based, and is responsive to population needs. Health reform aims to move to a payment system based on value. In doing so, it provides a climate that values prevention, addresses the whole person, and points to the integration as the next frontier. Today's focus on financing mental, emotional, and behavioral prevention goes directly to the point of establishing new roles and new responsibilities in relationships. The possibilities include clinical prevention, connecting medical patients with behavioral health resources, and population health, addressing the prevention needs of communities and at-risk populations as a basis for long-term improvements in health and costs. New financing approaches address persistent constraints such as unstable and fragmented funding and patient and illness-based insurance payments. Today you will hear about new approaches such as patient-centered medical homes, accountable care organizations, capitation payment, blended funding, on Community Wellness Trust. You will also learn about new approaches in 3 states. Whatever the financing mechanism, mental, emotional, and behavioral prevention providers must be part of the change process. Efforts to innovate mental, emotional, and behavioral primary prevention financing is an exciting and full of promise. The prevention community must become part of the process with payers, providers, and state leaders. We have to be proactive in making the case for what we do in prevention to improve the nation's health. Yet it is important to recognize that this work is barely in progress. Research and demonstration will be ongoing. Your perspective will be a welcome contribution to emerging opportunities to advance MEB prevention. I hope you find today's discussion beneficial. Please don't hesitate to use SAMHSA staff as a resource as you address MEB prevention issues in your states and communities. And thank you.
Thank you, Richard. That's terrific. I'm really glad that we got those problems cleared up and that you joined us. And again, you've done a terrific job in starting to highlight, I think, some of the important trends in financing and some of the challenges that we face. What I'd like to do is start to detail for you the issues in terms of some of the challenges that we're facing. You know, we really have many indicators in our contemporary society in the U.S. that we are having severe problems with our human capital. We have tremendous inequality in our system in terms of the rich and the poor. In terms of criminal justice, we have the highest incarceration rate in the world. Our incarceration rate is almost 10 times higher than that of France, 7 times higher than that of China. And I think that all of us are increasingly aware that many of the people who are in our jails and prisons are there with behavioral health disorders. If you look at our competitor nations, the nations in the Organization for Economic Cooperation and Development, the OECD nations, the U.S. Typically is near the bottom of those nations in terms of our status in terms of reading, science, and mathematics. And we've actually over the last several years dropped, even though we've had a tremendous focus and effort to try to improve our educational achievement. We're moving south, the wrong direction with regard to that. And we live in a very violent nation. We have the highest rate of gun deaths in the OECD. In our comparison nations, they're 10 times higher than the next country down. We have many problems of violence, poverty. We're slipping educationally, and our criminal justice system is really a concern. The issue of workforce is one that, as our academic achievement slips, the ability for our occupational achievement starts to slip, and the overall competitiveness of our organization, of our country, starts to slide. So those are the ain't it awful. There are a lot of things to worry about. It's a very brief tour. We have papers that will be available which detail in much greater depth these concerns. The interesting thing about this, though, however, is that we know an awful lot about what we can do to address these problems. We know, importantly, what risk factors increase problems in behavioral health, subsequently academic achievement, subsequently occupational health, and we know how to promote protective factors, those factors that help to buffer the risk factors. And the risk factors are many in variety. We're going to focus specifically on toxic stress and trauma here in terms of laying out our general theory. We know how to improve environments, and we know how to give individuals and families their tools and skills. We have a very strong science base here. What we don't have is the necessary political will or infrastructure to make that science base live in every community. And part of what we're doing today is realizing that a very important part of that infrastructure is financing. And I think there are actually some very encouraging things on the horizon with regard to the availability of financing. This is a general theory that we are sort of proposing to help us think about the things that are underlying the problems that we have in our human capital, and why it's really in all of our enlightened self-interest to raise that political will and to develop the infrastructure necessary. we start with the clear indication that we don't all come off the assembly line exactly the same. There are big genetic differences between us, and we understand that our genetics plays an important part of our development in terms of helping to shape the kind of person we develop into, the kinds of skills, attitudes, beliefs that we may ultimately have. What we want to do here, though, is we really want to highlight the interaction of genetic vulnerability with toxic environments. And here we're going to particularly talk about stress and trauma because we know that the exposure to stress and trauma, particularly in childhood, can actually result in changes to the structure of our brain, to our immunological system, and to our endocrine system that have come to be known as biological embedding. And the earlier these toxic stressors are encountered, and toxic stressors are things like child abuse and maltreatment, living in uncertain economic conditions, experiencing violence, having people in your family who have mental or emotional disorders. Kids who are exposed to those without some sort of ameliorative protective factors have changes in their neural systems, endocrine, et cetera, that result first in behavioral health problems, problems in learning and memory, problems in emotional control, and there's really overwhelming evidence that exposure to those in children leads to a wide range of problems in mood and cognition and thought. Those problems in turn underlie and undermine successful academic achievement. And as successful academic achievement is compromised, ultimately occupational achievement is also affected. So people who are not successful in school are much, much less likely to be successful in terms of their occupational choices. We know that socioeconomic status, one of the definers of it is occupational achievement. And then we know that people who experience lower socioeconomic environments are much more likely to develop other chronic illnesses as well as to continue to have behavioral health problems, which only leads to a vicious circle such that they're further exposed to greater toxic stress. We feel that, and the science strongly supports the fact that we understand many, many elements in this theory and that it is in our enlightened self-interest to do something to implement it. So we need to target funding towards prevention rather than treatment, move upstream. It's actually both prevention and treatment. Coordinate preventive interventions across sectors. We'll see in a second. And Sarah will discuss how we have a very sectorized, siloed system with regard to our investments in prevention, particularly primary prevention. It's really important that we identify sustainable financing mechanisms, and we're going to talk about some very exciting examples today. And it's critical that we measure the impacts of these interventions. As Max will highlight later, it's essential that we improve our analytics, that we know what we're doing, and we can make very strong cases for the value of what we're doing. So that's the prevention. What are the barriers to prevention interventions? They're administered by multiple sectors. They come from diverse and uncoordinated sources. Prevention intervention technologies differ and overlap between sectors, and outcome measures for prevention interventions vary by sector. So sort of the bottom line in terms of the real drivers of these barriers have to do with the lack of sort of a coordinated, coherent overall strategy for combining our resources. And this is what we call kind of the Rubik's Cube of prevention financing. You know, preventive interventions have broad-scale impacts and benefits across pretty much every area of human performance. And so it's not surprising that when we look at financing interventions for prevention, they also are spread across national, state, and local levels, so it's level of organization. They're spread across financing sources. Lots of money in public financing goes into things that are relevant for primary prevention, but private financing and philanthropic financing are also very important in terms of these interventions. And finally, as I said earlier, pretty much every sector, every human service sector, from education to health to behavioral health to juvenile justice, are involved in interventions that have something to do with healthy human development and prevention. So our challenge is in some sense trying to conceptualize this broad array of our current investments to develop a coordinated leadership structure that will allow us to understand what we're getting from these investments and the areas that aren't well addressed, And this is kind of the dilemma that we confront. As part of our trying to deal with these issues, Sarah and I have been working on this paper and some other papers in which we both detail the sort of general theory and try to develop this compelling argument for moving forward, but also try to identify tools that might help us understand the funding environment. And Sarah's now going to pick up with a discussion of the various sectors involved and some resources that we developed to help people understand those sectors. Sarah?
Thank you, David. And thanks everyone for being on today and participating in this webinar. This sector chart is just a portion of a resource that David and I created to accompany the paper that he has been referencing regarding to try to get a sense of where each sector is with who's involved, how primary prevention is financed, what types of interventions and technologies are used, and then the various outcomes that are tracked. So many of us on the webinar probably identify ourselves as stakeholders within a specific sector. We work separately on these issues generally. Right here I have just the mental health and substance abuse sector and the education sector highlighted. We also included in our resource maternal and child health, early childhood, community development, public health, general health, juvenile justice, child welfare. So all of those sectors, as was demonstrated on our Rubics cube of prevention financing, are interested in healthy development of communities and individuals. And so if you look at this, we have stakeholders that vary between the mental health and substance abuse sector and the education sector. There are different federal agencies, there are different state agencies. On the ground, there are, we have behavioral health providers and different advocacy organizations and professional organizations. Providers in the education sector are teachers and educators and school social workers and those who are working within that sector. Financing strategies, there's different funding, although you'll notice that there are some overlapping financing sources between the two sectors that go toward primary prevention. We have insurance in both of those buckets. There's school health clinics that are popping up, becoming more prevalent within the education sector, but of course there's a huge amount of financing for behavioral health and potentially for behavioral health primary prevention is within the insurance with Medicaid, TRICARE, and private insurance. And we're going to get into some of those potential insurance mechanisms with our examples and later in the presentation. And then when we move to the interventions and technologies, in behavioral health and mental health and substance abuse, we kind of claim screening and clinical prevention. We obviously have environmental strategies that we utilize, but we also have some overlap with education. One good example is Safe Schools, Healthy Students, which originally was an HHS, Education and Department of Justice initiative, and the awards are made to either state education or state behavioral health authorities. So those are some strategies and technologies that bridge those two sectors. And then when we think about the outcomes that we're looking at, what we want to achieve with primary prevention interventions more broadly, we're looking at very, very broadly healthy development, but mental health and substance abuse, we're really concerned with positive promoting mental health, reducing mental health and substance abuse conditions, some of those more specific indicators that you can see on the slide. Whereas in education, those stakeholders are generally more concerned with educational attainment, getting kids through school and getting them graduated and launched into the workforce successfully. So this just kind of illustrates some of the challenges and the opportunities for collaboration that are presented. We want to talk a good bit today about health financing for prevention. We do not currently utilize much of our health financing for prevention. As you can see, only 3% of total health funding goes to prevention. Our healthcare system is pretty insurance-based, and we're focused on treatment, getting people help for conditions that have already developed rather than moving upstream, as we've been talking about, to prevent those issues. And given the impact of social determinants on health and the interrelationship between health and social and economic outcomes, we really need to be concerned with utilizing health financing for prevention. And we're going to explore some of the ways that we can do that today. And here are some more specific barriers to using health insurance in particular for prevention. One is the historic need for medical necessity criteria. In order to get a service, you need to have a reason to get that service. And so you generally need to prove that you have a condition or a symptom that needs to be treated, which obviously doesn't fit into a mold of preventing conditions or problems before they even occur. And then based on much of the financing is based on performing procedures, a fee-for-service type structure, rather than on health outcomes or keeping people healthy. We've had historically beneficiaries have moved between insurance carrier and insurance payer. When you lose your job, you usually lose your insurance, and so you're either end up uninsured or end up on Medicaid, or if you find a new job, you're often with a different health insurer. So those payers do not have an incentive to keep you healthy because they might not have you in the next month or next year. Up until January 1st of this year, thanks to the ACA, this is no longer, but up until January 1st, insurers were able to deny coverage based on pre-existing conditions. So if you were sick and you were expensive, then you could just get booted off, and that took away an incentive for insurers and payers to keep you healthy. And then lastly is a focus on the individual beneficiary, that rather than a family or population health approach. So if you have a different insurer than your kid, then it was very difficult to get a parenting intervention covered that would benefit your child, because you weren't you were going to get the service, but you weren't the beneficiary of the service. So it made that difficult. Thankfully, in 2009, 5 years ago, we had the passage of the Affordable Care Act, which really kind of changed the landscape of what we're talking about with health insurance, and also really increased the focus on population-level health. One of the big overall wins in the ACA is a move to universal coverage. It's really changing the orientation of the healthcare system from a treatment focus to prevention focused. With the Medicaid expansion and the insurance marketplaces, we're, especially in states that have adopted the Medicaid expansion, we're looking at most people having access to health insurance. And when most people have access, then there is a collective incentive to keep people healthy. In trying to get everyone covered, we can focus on population-level health, and we don't have to think about individuals. Of course, we have to think about individuals, but we can move from an individual focus to focusing on larger groups. One example is occurring in Vermont. Vermont is nearing universal coverage. They implemented some reforms prior to the ACA to expand health insurance, and they have developed a tax, essentially, on each beneficiary in the state. Whether they're covered by insurance or Medicaid, or private insurance or Medicaid, there is a fee that's placed on per person per month that goes to preventing chronic illnesses and managing chronic illnesses and connecting people to primary care. So regardless of insurance status, whether you have public, private, or no insurance, you have access to these community community teams that are trying to get people covered and keep people get people into care and keep people healthy. And there's the incentive for all of the payers and the community at large because it's keeping everyone healthy in the state and everyone is covered. One of the major parts of the aspects of the ACA that many people think about is grant funding through the ACA for primary prevention. The Prevention and Public Health Fund allocates a lot of funding, billions of dollars over the next several years for primary prevention. The CDC has community transformation grants that address population-level health. SAMHSA has been involved in the National Suicide Prevention Strategy implementation and some other projects that are funded by the Prevention and Public Health Fund. I'm going to keep moving here quickly. The essential health benefits. There's a requirement in the insurance marketplaces and the Medicaid expansion that clinical prevention is covered. The U.S. Preventive Services Task Force recommendations A and B that get A and B ratings must be covered at no cost. And then the last is risk-based financing, which is a segue into the work of Jennifer Webster in Oregon, who's going to address is going to discuss what they're doing with their coordinated care organizations and their use of primary prevention in schools. These are capitated plans that the insurers, the providers get a certain amount per month to cover each individual, and that's all they get. So it's not based on fee-for-service, but it does require some coordination to keep those costs down, and that it needs, and that coordination and that care is moving towards prevention to keep people healthy rather than just manage chronic illnesses. So I want to introduce Jennifer Webster, who's going to give us a better sense of what that risk-based plan is. Jennifer Webster currently serves as a senior community health analyst in Lane County Public Health Prevention Program. Her work is primarily focused on implementing evidence-based strategies to improve the health of Lane County's Medicaid population. And she's going to tell us about the implementation of the Good Behavior Game and evidence-based practice in Lane County, Oregon public schools. Jennifer?
Thanks, Sarah. So first I was going to start off with a little overview of what Lane County looks like. So for those of you not familiar, we are about 1,400 square miles, roughly the same size as the state of Connecticut, and bordered on the east by the ridge of the Cascade Mountains and to the west by the Pacific Ocean. We're home to about 350,000 residents, approximately 2/3 of which live in the Eugene-Springfield metro area. And as of June, with Medicaid expansion, about 25% of our population is now on Medicaid. And since I'm going to be talking about a school-based intervention, I wanted to mention that we have 16 school districts in our county with 68 elementary schools. And of those, 39 have a 50% or greater enrollment in the free and reduced lunch program. So to give a little background on the formation of coordinated care organizations, in 2012, the state of Oregon received a waiver from Centers for Medicaid to demonstrate how to achieve the triple aim of reducing costs, improving care, and improving health. And so we were able to form what we call coordinated care organizations and are referred to in the Affordable Care Act as accountable care organizations. So there are currently 17 CCOs throughout the state. And in Lane County, we're fortunate that we have one CCO that covers our entire county and only one CCO. Several counties are either covered by multiple CCOs or CCOs that cover multiple counties, which creates complications that we are fortunate not to have to deal with. And since I get asked all the time, how did we manage to get this funding for primary prevention through our CCO? We are very fortunate that we have a close collaborative relationship with our CCO. There aren't any other public health departments in the state that have this kind of relationship. And It's really due to some of the history of how we've collaborated prior to the formation of the CCOs. Lane County Public Health and Trillium's parent company were both involved in a local coalition to improve access to uninsured populations prior to the Affordable Care Act. That was known as the 100% Access Coalition. And so we have a history of partnership in that sense. We also, Lane County Health and Human Services managed the behavioral health arm of the Oregon Health Plan, or Medicaid, prior to the formation of the CCO. And with the formation of the CCO, behavioral health and medical or physical health had to be merged into one organization. And so we have that collaborative history as well. And as a result of that, Lane County Public Health senior staff was very involved in the writing of the transformation plan, which was a requirement by the state for all the applicants to become a CCO. And because of our involvement in that, our transformation plan is the only one in the state that includes primary prevention. And so we have primary prevention, and then in addition to that, the Lane County was also able to secure a contract with Trillium Community Health Plan to help administer some of that primary prevention strategies. So currently, Lane County has 3 public health staff who are responsible for epidemiology, primary prevention, and community engagement for the CCO. So we have 3 staff members who are paid through this contract with the CCO. And so we're responsible for the community health assessment, primary prevention, working on the social determinants of health, and also doing work around wellness. And so in the transformation plan, there were 3 or 4 primary prevention priorities: reducing tobacco use, reducing obesity, improving immunization rates, and promoting wellness. And to do tobacco use, to reduce tobacco use, we came up with 4 strategies: incentivizing pregnant women to quit, training and supporting primary care and behavioral health providers, and using evidence-based cessation strategies, promoting the fax referral service of the Oregon Quit Line, and then reducing tobacco use initiation. And we had 2 programs that we are implementing as part of that, one of which is the Good Behavior Game. And so for those of you who may not be familiar with the Good Behavior Game, it is a classroom management tool that has been called a behavioral vaccine because of the numerous benefits that it has shown to have later in life for kids who received the Good Behavior Game in their first grade classroom. According to PAX, which is the organization that we work with to implement this, implementing the Good Behavior Game in the first grade can save up to $115,000 per student over the course of their lifetime. And there are lots of benefits to the Good Behavior Game, but the one that led us to really implement it was the substance abuse prevention that has been shown to reduce substance use initiation, including tobacco, by 25 to 50% by the time a kid is 15 and or 21. So as part of our contract with Trillium, in addition to the staff, we also have a per member per month set aside to implement primary prevention strategies. So that's where we get the funding to do things like the Good Behavior Game. And what we've been able to do in the last 2 years is train 85 new teachers. And we identified schools that have very high low-income populations. So we define that as 70% or greater enrollment in free and reduced lunch. And so we've trained 85 new teachers. We've retrained 16 teachers that we were able to train on a previous grant. And we've also trained 15 counselors and administrators as PAX leaders. And these are people in the school system who are there to support the teachers in implementing the Good Behavior Game. So based on average classroom size, we have increased the number of elementary students in a classroom with a trained teacher to approximately 1,300 students countywide, which if you remember the amount that we can save, it gets quite high and it's very impressive. So what we have now is about 50% of the eligible schools have at least one teacher trained. So we've increased the number of low-income schools that have trained teachers from 9% to 21%. In an implementation survey that we administered at the end of this previous school year, 60% of the trained teachers reported using the Good Behavior Game daily in their classroom, and 90% reported having used at least some of the elements at least once. And while our response rate on classroom disruptions is still really small, so we can't really say anything definitive with this, but it is encouraging to us that 50% reduction in disruptive behaviors is the average from baseline to 3-month follow-up. And what are we doing next? So we still have some more training to do. We're going to do another 3 trainings this fall. We have 2 rural school districts that are training all of their elementary school teachers. So we're working closely with them to help them institutionalize and make sustainable this program over the long term. We'll also be trying to train additional new teachers. Our goal is to have 100% of first grade teachers in low-income schools have training in the Good Behavior Game. And in terms of measuring our success for the short term, we're really just looking at reductions in classroom disruptions and teachers' use of the different elements of the game. And long term, we're hoping to work with Trillium to get geographically based data on attention deficit disorder to see if there's reduced use of medication and also reduced diagnosis in the communities where the schools are really utilizing the game. And then we also have a student wellness survey that's conducted by the state in the 6th, 8th, and 11th grades that asks behavioral risk questions on substance use, and so we'll be tracking those over time as well. And then I think the only other thing I'm going to add to that is that beyond the Good Behavior Game, we are also working to promote parenting education and support through programs like the Triple P and Family Checkup to improve mental health, and that's an upcoming strategy as well. Thanks.
Thank you so much, Jennifer. And we will have time for questions in a few minutes. And we know that you have many questions to get some more details on that innovative financing strategy. And David always jokes that all good things come out of, well, either Massachusetts, Vermont, or Oregon, or Massachusetts, so, or Washington, I'm sorry. So, but I will talk very briefly about a couple CMS initiatives, one of which is in New York. They have a 1115 waiver, the delivery system reform incentive payment, that is very, very new. It's just getting started there, so much remains to be seen. But we know that there is a focus to reduce avoidable hospital admissions by 25% over the next 5 years, utilizing largely service delivery reforms, but there's also a focus on population-based strategies and an encouragement of collaborative networks for systems reform. And some of those population-based strategies that they have named include promotion of mental health and prevention of substance abuse and promotion of the health of women, infants, and children. So there is a focus in that that waiver that's going to provide $6.42 billion for this reform to move towards population-based prevention services in the state. Another use of CMS is waivers and flexibility is primary prevention in clinical settings. And we're going to hear from Scott Waller, who is in Washington. He's going to talk to us about Triple P and their use of Medicaid billing to implement Triple P's levels 2 and 3 in doctor's offices and primary care in the state of Washington. Scott Waller has been involved in substance abuse prevention efforts on a county, state, and national level since 1984. And in his present role as Prevention Systems Integration Manager for Washington State's Division of Behavioral Health and Recovery, he develops programs and partnerships that seek to maximize the benefits of prevention work. Scott will be telling us about his experience of implementing Triple P, a parent support program in primary care. Scott, I'm going to turn it over to you. Scott, you can press *7 to be unmuted.
Okay, there I am.
Yep, there you are.
Well, first off, thank you very much for the opportunity to talk about this. Good morning or good afternoon, depending upon where you're at in the United States. I want to give just a real quick background about the Triple P, Positive Parenting Program is the name. Triple P is the kind of nickname for it. It's actually been around for, it's a very, very long-running program. It's been around for about 25 years. It was developed in Australia, but only recently has it come to the attention of folks in the United States. And the main reason for that was a population-level study that was done out of the University of South Carolina by Dr. Ron Prinz, in which he found when he implemented the Triple P system in 9 counties in South Carolina and then had 9 control counties, that he was able to demonstrate a population level change from implementation of the Triple P program. That's a pretty fantastic thing when you think about some of the challenges that we're up against in prevention. So specifically, over the course of his study, there were 240 fewer out-of-home placements than would be expected. That's a 22% lower figure. Think about that in terms of cost. 60 fewer hospitalizations for ER visits of child maltreatment, and 688 fewer substantiated child abuse cases over the course of the study period. So 17% lower. Each of those has a cost of several tens of thousands of dollars associated with each of them. So if you're really talking about bending the cost curve. For us, what we were looking at, there are basically 5 levels of Triple P, and the first level is kind of a universal. It's a community awareness kind of piece. Level 5 is roughly equivalent to kind of a one-on-one or a very intensive kind of intervention, and these levels 2, 3, and 4 are where most of the work is done, and in standard billing practices with Medicaid, almost all of the work done by certified counselors in levels 4 and 5 can be billable as a piece of what they presently do. What can't is kind of these kind of more preventive levels, levels 2 and 3, and that's where we actually kind of focused our effort. Was what could we do, particularly to get primary care providers interested in doing this? So we actually used mental health block grant funds to support a pilot study in 3 very rural Washington communities. We trained 20 healthcare providers, including 7 who can bill Medicaid. And it's really, really important that Medicaid has very tight restrictions about who can and who cannot bill. So MDs, ARNPs, and physician's assistants are basically the folks who can bill. So we trained 20 healthcare providers in all, so that would include nurses and other folks like that. But of that 20, only 7 were actually in the cadre of folks who could bill. This is an example of a level 1 kind of effort. This is basically a billboard promoting Triple P and positive parenting. So why get primary care providers involved is probably the first question. And for us, we were really influenced by a couple of studies, one out of Massachusetts, one out of Connecticut, that talked about even though parents may not always do what the doctor says, they listen. And there are very few avenues for us to get into parents' lives and use people as messengers that they will listen to. There's the old thing about with parenting programming and that sort of thing that some parents stay away from parenting classes because they don't want to go. They don't want to be known as kind of the bad parent that needs repair. Well, in this particular case, you're taking little Johnny or little Susie to the doctor's office for a well child visit, and while you're there, the doc is asking you a couple of additional questions. And if you get a question like Johnny's having trouble getting to sleep or something like that, the doctor has a very, very low impact response to give to the parent, and the chances are that it's going to be followed through. Second piece about why Affordable Care Act and healthcare homes, primary care providers can influence the trajectory of problems through appropriately timed interventions. If we do this right, the theory is, if we do this right, we actually wind up with a reduction in folks needing that access to care level of mental health intervention. We actually head things off at the pass, as it were. And the fact of the matter is that we're interested in the well-being of patients as our doctors. Barriers, time. For meetings, for training, for delivery of services, for record keeping, etc. I've had conversations with several small general practice physicians who say that I'm just astounded the number of patients they have to see in a given day in order to make enough revenue to keep their business in business. And that's something that we need to recognize when we're working with healthcare providers. Medical practices are businesses, and there's little room in the course of the day for non-billable service. So even if there's a great heart and willingness, there may not be economically a way to move forward. Keys to setting up Medicaid billing. Jennifer talked about the relationship that she had with her CCO, and that, I will say, is probably the key to our success here. I am not a person that works with Medicaid very often. I'm not a Medicaid biller. I've not been a provider having to use our billing system. I did not have this experience going in, but I found a person who I refer to as a Medicaid angel. Who actually was very kind and supportive and explained to me how things work and helped me kind of navigate the system. And we also had the support of our state Medicaid medical director, because he was directly aware of the study from South Carolina about reducing child harm indicators. So the keys to setting up Medicaid billing for us were identifying appropriate billing codes. Some of you who are in the Medicaid billing business know that we're changing from ICD-9 to ICD-10, and with that comes all kinds of shifting sands and that sort of thing. But a real key for us was we started off with the thought that what we were trying to do was to provide psychological services. It was a mental health block grant, and therefore we needed to use psychological services billing codes. And what we found was that actually primary care providers were pretty resistant to doing that. That's not how they define their work. They don't provide psychological services. So we've now gone back and made two revisions to kind of the billing documents. The first is that they can either bill for the original psychological service codes that we had, or they can use regular kind of office codes like they would if you came in for a cold or flu or something like that. And the other piece was that we put much too much time in our billing codes. Our billing codes started at 30-minute increments, and as tightly managed as Medicaid is, you have to be very precise. You can't just put down 30 minutes if you only deliver 10. So we've now had to go back in and add in billing codes that actually allow for 5 and 10 and 15-minute increments as well. So these are some of the learnings we've made along the way that we've actually been informed, in those changes by the primary care providers. The key here is that these primary care providers, at the very front end of this, they had this new system. We thought it would be attractive to them because it basically pays for their time. So we're getting them to deliver a prevention service. We're getting someone else to pay the bill, if you will. So all of that seems really really great. But the psychological service code and the length of time were big impediments, so they really didn't bill very much. Since we've made these what I think are fairly small changes, since we've made those at about the beginning of June of this year, they're billing at a much increased rate, and it's just much more familiar to them. One other piece that we did not do, and it was common sense when someone brought it to us that we should have done, is when you go into a doctor's office, the doctor has a little has a sheet that basically serves as all the information for the billing department, and he goes through and he checks, or she checks, all the things that happened, and then in my general practice office, gives me that sheet, and I go up and give it to the front desk, and then they charge me my copay. And then from there, that piece of paper goes to the billing office, and it gets coded for payment. Well, these triple P services were not actually on that sheet. And so even when they were being delivered, they were not being noted. So we actually had to go in and change those in some cases, electronic medical records forms, but in other cases, just hand-entered forms to include basically a checkbox. And now they have a checkbox, and it's really easy for them. Referral protocols for patients who need more intensive behavioral health support. It's really, really important that primary care providers have some place to send them, and that requires very siloed systems to talk to one another, and they don't always do that very well. And so at what point is it too much for a primary care provider, and they need to actually refer the person out for mental health evaluation or substance abuse evaluation or something like that? Billing process in Washington State, we have a unified billing system called Provider One. So essentially, all of these codes are now recognized within that. So this is a piece of work that the doctor's office basically does now as a routine. And for us, probably the key to making this work is there's a fairly intense training associated with Triple P. You don't just get to pick up a book and go with it. You have to go through a training, and then there's a certification process. And it was at the conclusion of that certification process that we turned their billing authority on. And if they did not get certification, they did not get the billing authority.
Okay, thank you, Scott.
Sure.
I'm just going to ask a few questions here. Somebody is curious, does the Good Behavior Game lend itself to implementation through after-school programs that are delivered by other agencies?
Yeah, the Good Behavior Game could be implemented that way for sure. I'm not sure that there's any research on the long-term effects of using Good Behavior Game in after school. So I will say yes, it absolutely could be implemented in that setting, but I don't know what the research says about that.
Okay. And how about, is anybody aware of CBOs that are using Medicaid financing to do HIV prevention?
I am not.
I'm not.
Okay. One more question. I think that an individual was curious, Jennifer, as to just a quick reminder on your funding strategy to support your program.
Yeah, so it comes from a per member per month set aside that Trillium has agreed to for primary prevention. So it's $1.33 per member per month.
Thank you. Any other questions before we move forward? Okay, great. Oh, yeah. Oh, I see here. Are there any challenges with services being available after primary care physicians make referrals to other services?
Yes, there are, and it's the same thing that happens with all referral systems. Is there can be a breakdown in whether services are actually available, appropriate services, whether people actually follow through on those services, and what the communication is from the person that's referred to back to the referrer. So all of those places can have cracks, and you need to. That's what I was speaking about. You need to build a referral system that kind of addresses all of that.
Okay, great. Someone wants to know, have you found that transportation is a problem in implementation of these programs?
Yes, and it has been a problem. PPP is set up for multiple sessions, and what we're finding is that largely folks, at least in the primary care setting, will go to the one, but they generally won't come back for ongoing services, largely because of the transportation cost. And we're working on some telehealth kind of options for that, as well as trying to find some other ways of providing that, providing those services where they don't need to travel.
Great. Any other questions from our community? Jennifer, where are you getting the data on the success for the Good Behavior Game?
So right now we're relying on teachers and school staff to do to fill out implementation surveys and to do classroom observations for us. And we're having kind of mixed results with that. We have some schools that are being really awesome with providing us with that data, and some schools not so much. And then for long term, we're really looking at the student wellness survey that we get from the state, and we're also working right now to get district level data from the districts for that survey.
Wonderful. Any other questions? If not, we will be moving forward. I believe David or Sarah is going to introduce our next speaker, Max.
Yeah, I'm gonna take over for a while. Thanks, Teresa. Thanks to both Scott and Jennifer. That was excellent. If you thinking about Sarah's introduction and the fact that only 3% of current expenditures goes to prevention, the vast majority of expenditures for healthcare comes through one sort of insurance program or another. These are really sentinel kind of interventions that start to address some of the primary concerns and limitations in health insurance mechanisms. The Lane County example has really transformed the notion of having to have medical necessity, number one, having to have services only delivered to a primary beneficiary, number two, and they did it through a very clever and approach which has a lot of integrity related to specifically reducing substance use conditions, and that's because we've got good long-term 13-year follow-up data on experimental subjects, the experimental classrooms that were enrolled in the Good Behavior Game. So the work in Lane County is really transformative. And then the work that Scott and his colleagues have done in Washington similarly, and Scott presented a lot of the detail that goes into these. It's one thing to sort of have something conceptual in mind, but it's clear that they've really gotten into the nitty-gritty details of making something like this happen. But again, their intervention both dealt with some of the stigma associated with seeking behavioral health services, which is an issue outside of healthcare financing specifically, but I think very importantly started to sort of broke this barrier around delivering services to parents that benefit the ultimate beneficiary, which is the child in this case. Sarah and I were so impressed when we found out about both of these interventions. And another point that Scott made, which is a little bit different than the point we're making right here, is the importance of the social relationships that we have with one another. It's interesting that the last question was about where do you get data. Jennifer talked about their data collection efforts. And something that's really sort of emerging, I think, and is very exciting, is the potential interest in private funding for these kinds of interventions. I think as we understand more about the cost offset or the return on investment that one can realize from these kinds of interventions when they're appropriately implemented, we not only attract businesses who are concerned with the health, well-being, and productivity of their employees that might be expressed through workplace wellness programs, but to the degree to which we can increase efficiency in social programs overall, we can start to realize a return on our investments in terms of increased human productivity and decreased overall social costs. And that has stirred some interest in what are called pay-for-success contracts or pay-for-performance programs, where in some instances private investors, individuals who would buy a municipal bond to build a water treatment system, for example, are able to, or will hopefully one day be increasingly able to buy a social impact bond and help underwrite the development of an intervention that will improve the overall health and well-being of the population. In order for that to happen, it's really important that we have the analytic capacity to answer the question that Jennifer was asked in terms of how do you know you're having this effect. We're really happy to be joined by Max Crowley, who earlier I referred to as Max Weinberg. So Max probably wondered how he had gotten promoted to the E Street Band with Bruce Springsteen, and hopefully that wasn't too big of a faux pas in terms of making people think that Springsteen concert was going to be part of the webinar. Max Crowley is an NIH fellow at Duke University and has really a very interesting background in terms of being a health services researcher, a person who's very knowledgeable about prevention interventions, but who also has an economics background and can really very powerfully address the intersection of prevention methodologies and economic benefits. And he's going to tell us about, and I'm noticing that I didn't do Max's picture. There's Max. He's going to tell us about what's happening in this really exciting new field. Max? And just remember, it's pound. You have to do #7 to unmute yourself. Oh, Max is still signed on.
Max, it's *7.
Oh, yeah. Thank you, Teresa.
Hi, David.
Hi, Max. I'm sorry for the bad introduction and then the bad technical advice.
No problem. No, it's great to be here and get to talk about this really interesting topic with the group today. And thank you for the introduction and also the background. I think it's really important, and I'll talk more about that as well as we think about where is the data coming from and how do we actually how do we deliver prevention, primary prevention programs, and then how do we make sure that they're working as they were intended. And so in that context, I'm going to provide a brief introduction on this relatively new area of funding known as Pay for Success, or PFS. So PFS is an outgrowth of performance-based contracting that has become particularly valuable for tying contract payments to the actual receipt of products or services. So Pay for Success financing applies this approach to the delivery of health and social services, tying public payments to verifiable outcomes, as we were just talking about. So specifically, a PFS contract leverages private investment in interventions to prevent downstream public costs. So if the public cost diversion is achieved, then government shares the savings with the private investors through a repayment of their initial outlay, which was used to fund the delivery of the program, as well as a small return on their investment. So one of the common structures of such a contract are known as what they refer to as a social impact bond, which rely on an independent evaluator to determine if cost diversion has actually occurred. And if it has occurred, that triggers a performance payment. So a payment back to the investor that is contingent on the performance of the program itself. So, but if the program fails to achieve this agreed upon level of cost diversion, then the performance payment is not triggered. Yet what's important in that context is that the public resources aren't necessarily at risk. So if the performance payment isn't triggered, then depending on how the bond is structured, either the investor loses all their money, or there may be a philanthropic donor who's provided a backstop where they've essentially they would provide the investor with some return on that initial payment, but they would lose. So the idea here is to move risk out of the public sector around investing in prevention and move it towards the private sector. But the incentive is that if the investor picks the right program and funds that program, then and that program does meet that performance payment trigger, then they receive this additional return on investment. That could be anywhere between 5 to 12 to 15%. We've seen a variety of different such contracts. So PFS contracts then allow the public entities to engage in new financing sources to meet these pressing social needs that we've been talking about today. Specifically in the context of diminished public budgets, government can turn to the private sector for investment in mental health and welfare. And when a program has this strong evidence, such as the two programs that we are actually talking about today, that can achieve a significant cost aversion, but spending concerns block its support, then government can incentivize private investment in the program by offering to share in this eventual downstream saving. So we're finding that there is substantial demand among a broad class of investors to support such programs. For instance, it took Merrill Lynch only 6 to raise $13.5 million to support a New York State Pay-for-Success contract that is currently delivering cognitive-based therapies to juvenile offenders who have recently been released from prison and from being incarcerated to prevent them from going back to prison, so for preventing them from recidivating. So investors in this deal include former U.S. Treasury Secretary Lawrence Summers, Utah philanthropist James Sorensen, and the Laura and John Arnold Foundation. So while the cause of reducing juvenile reoffending may be in the public interest, these investors, such as the ones I just mentioned, stand to realize an annual return of up to 12.5% over a 5.5-year period. Such investments illustrate that funding for social programs may in fact be available when thoughtfully framed within this PFS or Pay-for-Success structure. So in 2010, the first Pay-for-Success contract was signed in Peterborough, England, to prevent recidivism among juvenile offenders. And in this agreement, investors funded a program to reduce reoffending among prisoners leaving the Peterborough jail, similar to the New York Pay-for-Success effort that I was just referring to in New York State. And if reoffending was lowered by 7.5% within 6 years, then the UK government will pay the investors back their initial investment and a share of the savings from having to incarcerate fewer youth. So interim findings from this trial are highly promising, with 12% decrease in reoffending compared to the national average. Now in the United States, the past 2 years have seen an exponential increase in Pay-for-Success interest and implementation. So the first was through a contract between Goldman Sachs and New York City to prevent recidivism of juvenile offenders on Rikers Island. And another Pay-for-Success contract was in Salt Lake City and sought to reduce special education costs with a high-quality preschool intervention. A Pay-for-Success contract that's currently underway in Fresno, California supports a behavioral management program for children with asthma in an effort to reduce their emergency care costs to the state Medicaid system. So numerous other efforts are being driven both by policymakers who are interested in this area as well as by private investors. But now I'd like to step back and with the remainder of my time consider what the structure of a Pay-for-Success contract can look like and who the key stakeholders are, particularly those in government and those who are nonprofits at the state or local level. So while many of these efforts have initially focused on efforts that target specific population, this financing strategy can be applied to primary prevention when savings are known to exist. And as I mentioned, the two programs that we've already talked about today already have strong evidence of not only being effective but having an economic impact. So some of the programs, so Pay-for-Success financing centers around contract development in multiple groups in an effort to align stakeholder incentives around supporting social services. In this manner, they are a new asset class that can funnel private sector resources into private sector resources into the public sector. So I'm going to talk about one pay for success effort in particular today, and that one is focused in New York City, and is between the City of New York, MDRC, and Goldman Sachs. So this contract between them, in this case, the investor, Goldman Sachs, provides the resources to allow the Osborne Association and Friends of the Island Academy to deliver a cognitive behavioral therapy before the juvenile offenders are released from incarceration on Rikers Island, and then provides behavioral support after they leave from Rikers Island. And so this population, the juvenile population, is then tracked through their criminal records, through their records, to determine whether or not they recidivate back into not necessarily Rikers Island, but back into the system at all. And so an independent evaluator, which is in this case the Vera Institute for Justice, is evaluating using those records whether or not this program actually saves the City of New York money, resources. And if it does, in that context, then there's a payment made through the Bloomberg Foundation in this context. So there's an additional philanthropy involved in this case, but in other social impact bonds, it's perhaps directly the government paying. For instance, in Salt Lake City, that's the city of Salt Lake City is the payer who would make the performance payment back to the investor. If the Vera Institute for Justice finds that program did work, then Goldman Sachs receives their initial money back as well as a 12.5% return. So now I just want to kind of discuss a couple key points that in particular are really important in terms of take-homes here. And that is that pay for success financing is a rapidly growing area with, and that there is this tremendous, but it offers very interesting opportunities for financing some mental health services, but this approach is not without inherent risks and pitfalls. In particular, there are concerns that the financial motivation within pay for success financing may bias efforts to evaluate the success of different programs, and this is spurred by the tremendous appetite for socially good programs that I discussed earlier. So while this makes high quality, this context makes these high quality independent evaluations crucial to the effort. So this is where data and understanding the analytics are particularly important. So already, though, we're seeing millions of private dollars entering into the mental health space because of this financing model, but there's much needed support. This much needed support, though, while very valuable to the clients and families, it is also important to be strategic as we move forward. So further, we also need to recognize that investments in mental health are likely to lead to substantial savings outside of the mental health system, as seen by savings that we're already seeing in juvenile recidivism. But this requires us to move past many of the silos that Sarah talked about earlier, because we often see that an investment that we may be making in mental health may result in an accrual of benefit to the physical health system, the education system, or potentially the labor market, or reductions in criminal justice costs. So finally, there is a concern that many of the evidence-based programs currently available may lack crucial information needed to develop these robust performance metrics. And all parties interested in pay for success contracting should consider multiple elements as they move forward. First, it's important to consider how evidence of a program's impact translates into fiscal cost aversion. In particular, there is a need to closely evaluate how uncertainty in program effectiveness and cost projection influence performance payments. And second, the availability and quality of administrative data to meet performance evaluations need to be established early in the pay for success development process. So the promise and possibilities of pay for success financing appear many, but we do need to keep in mind that it's a financing model, and every effort is going to be different as we move forward.
Great. Thank you, Max, so much for your presentation. And thank you to all of our presenters. We're at the end of our webinar, and so we're going to open up to the community for questions. And so if anybody would like to ask a question, I just want to remind them to go ahead and type into the comment box, and we will forward them to our presenters. For a first question, who pays for independent evaluators, the investor, intermediary, or government? I believe this is to Max.
Yeah, so that's a really interesting and important question. Generally, what we've been seeing is that part of the investor's costs are the costs to do the evaluation. So they are not directly contracted with the independent evaluator. In the context I was speaking about before, there's an intermediary. In this case, it was MDRC in New York City that hires that independent evaluator. So the investor and government don't have any direct relationship with that evaluator, but the actual evaluation is paid for by the investor. And if the performance payment metric is met, then that evaluation cost is returned by government as well.
Okay. Well, are you aware if investors are likely to be more involved to ensure that they get a return on their investment?
Well, I mean, it really depends on how we define involved. I would say that already we're seeing, folks like Goldman Sachs and Bank of America Merrill Lynch are really interested in mental health services and substance abuse prevention and talking about data and evidence-based programs in a really robust fashion. So they are involved already to just in a hugely different, qualitatively different way than we saw before. Now, in terms of their involvement in each individual contract, they definitely have their actuaries looking at the estimates and negotiate. In terms of on the ground, some not of, and because I have to evaluate independently.
This question, I'm not sure if Jennifer is still there. Jennifer?
Yeah, I'm still here.
Oh, wait, great, wonderful. We do have some individuals who are really interested in the Good Behavior Game. Do you know where they can go to find longitudinal studies on the effectiveness of the Good Behavior Game as a prevention program?
I would recommend going to goodbehaviorgame.org, and in the About section there's a thing on scientific outcomes, and it lists some of the research that's been done.
Oh, wonderful, thank you so much. How about what research is available regarding cost-benefit of prevention interventions?
Max, do you want to take that?
Yeah, I can probably jump in on that. So there's a variety of evidence available in terms of different types of programs. There is no true clearinghouse for all of that information. Some of it is in the academic literature. Some of it can be found in reports that come out from state and federal government. But one place you might want to look or start with is at the Washington State Institute for Public Policy. You can just search for that online. And they have a very robust kind of benefit cost model for helping inform policymakers about the benefits and the costs of different prevention strategies. And so that's a good place to start. And they have an extensive reference list that can send you in different directions looking at different programs, including the Good Behavior Game and Triple P that we're talking about today.
Wonderful. Also, how can we be sure that savings from these programs are used for addressing social determinants or behavioral health problems, not programs?
So,
yeah,
I think it might be. So I think if I'm understanding the question, the performance-based contracting approach is one way to guarantee that, right? So we might convince a state legislature to invest in a program because it's going to have savings, but that savings is never redirected back towards funding that approach, and the approach is no longer sustainable and it goes away. A performance-based contract is one way to ensure that that government then may recycle essentially that savings back to supporting the program. They may wish to fund the program on their own, and then they don't have to share the savings anymore with the investor. And so in this way, a pay-for-success contract can essentially prime the pump and demonstrate to government and to the public sector that this is a program that really does have savings and cost diversion for government and taxpayers.
Wonderful, thank you.
This is Sarah. Can I just piggyback on that?
Yes, please.
One one strategy that we didn't mention earlier, and that Max was just discussing in social impact bonds or pay for success contracts, is reinvestment compacts. But that doesn't have to be exclusively used in private investment. If we have those good data, like the cost-benefit analyses that the Washington State Institute for Public Policy has demonstrated in their analyses, and if we have good data at the state and local level, we're able to identify what those savings are and then ensure that they are reinvested either into the same program to ensure sustainability or into other related programs that are moving upstream into prevention and addressing those social determinants. So it doesn't necessarily have to be just on the private side. And I know that one really interesting thing that Scott's working on in Washington State is integrated data across human service sectors within their state. And I don't know if Scott wants to just, we have a few minutes, but if Scott wants to just say one or two things about how their data system is integrated, really high level, who's involved and how the data is used. That might be useful for those on the line.
Yeah, I'll tell you as much as I know, and that will take about 10 minutes, or 10 seconds rather.
I was going to say, 10 minutes is too much.
Sorry about that. No, it's this has been a project that we've been working on for probably the better part of 15 years, and it's essentially trying to match up all of the information that we have from our Medicaid services and other public pay services with things like employment and things like traffic records and a number of other things like that. So essentially what we have now, educational outcomes are in that mix now. Essentially what we have now is the ability to go in and kind of search by, multiple different factors for what happens with an individual. For instance, if they're on public assistance for this long a period of time, what happens if they get this kind of a medical intervention or those kinds of things. So we have all kinds of pieces of information that we can tease out with that. It's a very cool system. I really haven't been involved much in the development, but it's very cool.
Great. Are there any other final thoughts from all of our presenters?
Well, I'd like to thank everybody, in addition to Teresa's thank yous, and just sort of review for just a minute or so kind of what the case that we built, and I think some of the really exciting stuff that's been presented. Our argument essentially is that we're really confronting some very significant problems in terms of the health and well-being of our country, and that we have a substantial theory to help us understand some of the root causes underlying that, and a pretty formidable armamentarium of pretty well understood interventions that can bend that curve. One of the things that we have to solve in order to be able to bring these interventions to their full life and benefit for our communities is how we go about paying for them and establishing predictable, understandable mechanisms that can underwrite them, which has not been the case in our country before with regard to having those mechanisms understood and strategically directed. I think what we see here today is some sentinel breakthrough kinds of approaches where the basic conceptualization of health insurance is starting to change, supported in large part by the Affordable Care Act and the increasing realization that we're never going to bend the cost curve or improve our well-being unless we move upstream. That seems to be more generally acknowledged than it has been in a long time. That these behavioral health interventions are high leverage, high benefit interventions, and that even the private sector is getting interested in investing in these, and through these very clever mechanisms that Scott talked about, we're able to acquire capital that we've never traditionally had. You know, in our field, we typically are robbing Peter to pay Paul, but if we could actually adequately capitalize some of these investments, it would be an extraordinarily new world for behavioral health. The strength of our science is in part what's causing these investors to get interested in this, as well as I think a genuine desire, Scott shared with us earlier, that their investments do social good as well as earn economic benefits. So I hope that when we reflect back on this time 5-10 years from now, we'll see this as an inflection point or a tipping point in terms of starting to address some really, really fundamentally important problems that we have and developing financing mechanisms that start to address and solve that Rubik's Cube and move us forward so that we can benefit from all of our investments. So thanks everybody for that. Teresa, thank you so much for your able narration and feeling.
I actually have one quick question for Scott that's come up briefly. Is there a website, Scott, that someone can go to for information about how Washington has integrated data from other agencies?
No.
Yeah.
not like that. If I think they have my contact information, and if they want to shoot an email to me, I can send them on to someone who can answer most of their detailed questions.
Wonderful,
Teresa,
great.
Teresa, also, it's a great opportunity for us to plug the paper. This presentation is based on a paper that Sarah and I have written that's not quite finished yet, but will be finished very soon, that goes through in detail the issues that were covered in the webinar. And among the things that are addressed in that paper is a description of the Washington State data system and some references that people can use to get more information about it.
Excellent. Wonderful. Thank you so much. And as Mental Health America, I just want to thank SAMHSA for supporting us, and together we want to thank everybody for their participation in today's webinar. Thank you, Sarah, David, Jennifer, Scott, and Max for your wonderful information. And as I said, the recording of this presentation will be available on Mental Health America's website within 2 weeks. And if you have any further questions, feel free to reach out to any of today's presentations, and we hope everybody has a wonderful afternoon. Thanks.
Thanks, everybody. Bye-bye.
Thanks.
Bye.